Everybody, welcome back to the Monday Afternoon Journal Club. Ed Bauter and Dan Schwester here today. Danny, today we're going to talk about oxygenation. This is a paper from 2019 out of intensive care medicine. And the reason we're going into the Wayback Machine to 2019 is to remind people how oxygenation works and about high flow nasal cannula. I want to give a shout out to our friend Haney Malamet. He talked about this paper on Instagram a couple weeks ago. But
yes.
Dan, this is a systemic review and meta-analysis in hypoxemic respiratory failure. And they looked at different oxygenation devices. You know, we love meta-analyses here on the Overrun. This is 9 randomized control trials for an N of 2,000. I do.
Do we though?
Do we though? But this had 9 randomized control trials for over 2,000 patients. So we're looking at a really good N. And essentially what they look for is how high flow nasal cannula works, as far as it pertains to needing intubation. So in patients with acute hypoxemic respiratory failure, high flow nasal cannula may decrease the need for tracheal intubation without impacting mortality. That is a headline that goes out, and that tends to get read, Danny, as high flow nasal cannula saves everybody. We don't have to tube anymore. We're done with it. That's it. It's nasal cannula for everybody and we can all go home. But that's not really what the study actually says.
Yeah, not so fast. And when we're talking about this study, they're talking about high flow nasal cannulas. We're not talking about the one in the back of the truck that you turn up to 25 on the flow meter and let it go.
That's an actual commercially designed high flow nasal cannula.
This is actually designed to provide oxygenation 50, 60 liters per minute for a long period of time. It provides PEEP. It does a lot of things with that. And it allows patients to breathe on their own. They also don't need to have a face mask. So when they're upstairs on this, a lot easier for them to get oral care, to eat, drink normally. These things are all good things for patients up on the floors and in the units. Now, what the studies showed was that really there's no difference between using one of these fancy high flow nasal cannula machines and regular oxygen therapy. It didn't decrease length of stay. It didn't decrease mortality. It didn't make a huge difference. Where it did make a difference that was statistically significant was in the people that did not get intubated as opposed to the other arm of the study. Now, we all know, listen, paramedics love intubating. We love tubes. We love airway stuff, but it's a potentially dangerous procedure. There's a lot of complications, and especially when they're on the unit or they're upstairs and they're on a vent, now we have to deal with medications. Now we have to deal with the sedation package. Now we have to deal with blood gases. Now we have to deal with all these other things that could potentially go wrong. The best possible thing for a person who's breathing is to keep them breathing and to keep them on a negative pressure circuit as opposed to positive pressure, because that's problematic over time. That's where I think the benefit to this is, and that's where I can see it starting to be used more and more for those people that might buy a tube, but we're trying to keep them off it. One that comes up to mind is like a DKA patient. This could be a really good thing for them. Or somebody who needs to maintain their respiratory status, and they need the oxygenation and PEEP, but we're not ready to tube them yet. So I think there's the benefit there.
And I think that's right. I think we tend to, we work in grays, right? Like it's very easy to teach in black and white, but we operate kind of in those gray areas. So we already should be putting a patient on high flow nasal cannula to prepare them for intubation, right? And this might cover that, sort of the, almost like the right tail of the patients that you see, where these patients might actually have an improvement in their respiratory status that's significant enough that they don't need intubation anymore. And that's reflected here in this actual data set. So to look at the conclusions real quick, here we see the number needed to treat so the best estimate for absolute reduction in the need for intubation was 4.4%, which is a number needed to treat of 23. So again,
good.
Yeah, because the number
that's really good.
Aspirin is something like 80.
Aspirin in ACS has I think it's in the 60s.
Yeah, it's so higher, right? So there is an actual statistical value to this. And the other thing I want to point out here is in this actual study, high-flow-nasal cannula had 0 instances of apnea in this one study, right? And again, this is a paper that was published in 2019, so this is data going back to 2015. We wanted to explain that, this isn't, using a high-flow nasal cannula in this setting isn't new. And this is the rationale for it, where you might have, and again, in here, there's a 4.4% absolute reduction. So consider the amount of patients you see in a year that are intubated, or that you have to intubate, whether they're an RSI, which again, RSI causes a whole lot of other problems downstream, because now you're introducing a paralytic, you're introducing a sedative, then, there's other talks of emergence reactions and all this other stuff. So these might be these patients where you can temporize them enough, just giving them a high-flow nasal cannula, that it at least bridges that intubation into a more controlled setting in the hospital, right? This isn't suggesting that, everybody that you give a high-flow nasal cannula to won't get intubated, but it might actually help turn around that small portion that is kind of going over the edge, and that high-flow nasal cannula brings them back a little bit.
Yeah, every little bit helps. Anybody that we can keep off a ventilator is a good thing. Anybody that we can keep from having to be sedated, intubated, whatever, what have you, trached down the road if they don't wean off, that's a win. And again, not something we're going to see a lot on the street as frontline EMTs and medics, but definitely in your critical care transport world, your flight world. This is something you're going to see. You're going to see these people upstairs. You're going to be transporting these people. And it's something to get familiar with and get yourself comfortable with, because it probably does a good thing.
Yeah. And I think, and again, one of the things that we like to talk about here a lot, Dan, is these studies aren't made for EMS. Right. Nope. And one of the problems with trying to look at data as an EMS provider is you have to kind of, there's data that's already that has to be extrapolated. Right. And then we have to kind of extrapolate it more for how it might actually apply to pre-hospital medicine. So I see this paper, and maybe you put high-flow nasal cannulas out on your trucks, right? I don't know what the price point is. I don't know what that would cost, but it might be where if you're in a system where you have long transport times, right? Going back to like the critical care transport aspect of it, it might be that you can put these patients on a high-flow nasal cannula and CPAP and at least save them the tube. And that might improve their outcome. So I think there is applicability to this in the field. What it is, I don't necessarily know. Right.
I'd rather have a really good BiPAP on my ventilator and be confident in using that. I think for the short distances and the short contact times that we as paramedics have, really good thing. But if you're out in a rural world and you got 2-3 hour transports, this might be something that'll save you from having to intubate that patient.
Well, and even
something to bring up.
Even on the BLS end, I think that this can open up a lot of interesting conversations where, okay, when you have those patients so how often do you think as a BLS provider, especially in our systems, you show up and the patient is already an extremis, right? And there's literally and objectively nothing that you can do. This might be one of those things like, okay, you put them on a high-flow nasal cannula, right? So now we're not worrying about temporizing them from the ER up into the ICU, but we're taking what we see in this paper and applying it to the field where they're being temporized from, the bedside to the ambulance, right? So maybe that's where this information goes. But and again, this is out of 2019, but this is something that we want to point out. We're like, this isn't new data. You're going to say every summer, it seems like we hear more about high-flow nasal cannula. There's always more data that's coming out about it. And again, Dr. Malamet talked about this on his Instagram page, but I wanted to bring it up because it feels like there's a lot of things that we do in pre-hospital medicine that are not novel. They're not new. And we still kind of conceptualize them as new. And I feel like high-flow nasal cannula is one of those things, almost like pre-hospital ultrasound, where there's not really a debate anymore about the efficacy of it, whether or not we should do it. And I feel like this paper kind of highlights that point where it's safe to use and it actually has a low number needed to treat, so you can actually improve patients by not doing a whole lot more. But we do want to know what you guys think. Are we using high-flow nasal cannulas? And when you do, are you using customized tubing? Or are you using standard oxygen tubing? Check out all the content that we have on YouTube, Spotify, and Apple Podcasts. Check out our news stories on EMS One, because the sun never sets on the Overrun Empire. But for Monday Afternoon Journal Club, I am Ed Bauter. He's Dan Schwester. We'll talk to you all next week.
Take care.